I'd like to welcome Ed Litton to the stage. Ed's recently joined us looking after the Critical Care Resources Registry. He comes from Fiona Stanley in Perth. Embarrassingly, he's far more energetic than Dave and I are in the physical activity he undertakes. He's going to talk to us about recent information we got in our survey about some workforce resourcing. Ed.
Thanks, Peter. Like Peter, I'd like to thank our staff at CORE. I'm a recent addition and very grateful for the opportunity of being part of the CORE team and, of course, all the contributing ICUs and our jurisdictional funders. I thought I'd just talk mainly about what CCR is and what we can learn from it and what you might be able to use it for, and really just use some of the examples around workforce to sort of describe it a little bit. I think CCR, in some ways, is the little baby brother compared to the big brother of the APD, and it can get sort of runs along for the ride, but can get forgotten a little bit. But it's a fabulous resource and perhaps is still somewhat underutilized compared to what it could be used for. CCR has been collecting data since 1993, I think, on an annual basis. So it's aggregate unit level data about resourcing that happens in the ICU, which is becoming more and more relevant, and it's got a fairly stable contribution as well of the approximately now 213 units across Australia and New Zealand. Roughly 170 or 75 to 80% contribute on an annual basis, and as well as the more detailed data we get from each contributing unit, the core staff make a big effort to get really the headline numbers from every single unit from around Australia and New Zealand as well, and that gives us the opportunity to come up with these sorts of tables and graphs. Here on the left, I've sort of put the States and New Zealand in order of the available public beds only, so not the private, but public beds per 100,000 of population. And the CCR can immediately give you an idea of the variation in resource availability that occurs across our countries. WA has the lowest number of available beds per 100,000 of population for the public sector, but then if you add in the private beds, it skips and jumps up above New Zealand. But there's substantial variation, more than you might expect over the states over time. And then here on the right, I put in the senior medical officer FTE per 1,000 of patient days, and there you'll see actually it's sort of narrowed down and the range is much smaller between states over time. So immediately CCR can give us this overview, both at what's happening in a snapshot and also what's happening over time. And this is really interesting too. So there again on the left, if you look at the senior medical FTE, actually in proportional terms, it's been increasing over the past 5 years at a similar rate in tertiary, metro and rural as a proportion of total, but of course in absolute FTE number, the greatest increase has been in the tertiary units, and similar trends also for the nursing FTE over a 5-year period too. So there's growth, substantial growth happening in all areas, although not the private. I picked out workforce because although CCR has collected really useful, valuable information on FTE over time, we chose last year to add in some more detailed information about workforce because of the level of interest in the community, I think primarily, and also what's available in the literature. So there's been a lot of work from other parts of the world looking at what is the relationship between bed numbers and outcomes. And actually from the UK has been the first real data, not just on beds and outcomes, but patients and the intensivists and outcomes. So Haley Gershengrom, a US intensivist, used the ICNARC database in the UK and concentrated only on the units that had a single intensivist working and collected the data from the ICNARC from about 2010 to 2013 and looked at the ratio of the number of patients to the single intensivist caring for them and their outcomes. and has produced some really interesting data. And here's, if you sort of conceptualize that there might be a sweet spot, what might be the competing risk between caring for too few patients and too many patients. On the one hand, too few, you have missed learning opportunities, you have clinicians shortages, you've got distracting other responsibilities, you have too few protocols, too rarely practiced, and on the other hand, you've actually just got too many patients. So there's always been this hypothesis that it's probably some sort of sweet spot. And in the UK, this is what it looks like. There's a U-shaped curve whereby if you're looking after too few patients, hospital mortality goes up, and if you're looking after too many patients, hospital mortality goes up. It looks fairly flat on this, but the absolute difference in mortality is substantial. It's around 3%. On either side of this U-shaped plot. And the sweet spot, at least in the UK, if you're a single intensivist looking after patients in your ICU, is around 7.5 patients. That's the sweet spot of the U-shaped curve. So if we take what we know from the CCR, to date we've really only had the bed numbers. So that's a useful starting point, but this is why we added in some of the additional workforce data, because workforce is changing in the ICU. There's a lot more pod systems, there's a lot more intensivists doing different roles. We wanted to capture a lot of that. So we've captured it both for the senior medical workforce and broken down in terms of what the shifts look like. So that data is now available for one financial year. And we've also looked at both the nursing resources available, core sort of clinical nursing, and what's the additional duties, and also the allied health, and what all those sorts of shifts look like. So from CCR, this is our bed to intensivist ratio, which is obviously different to patients. Just because we have a bed, we don't know whether we have a patient, but not looking at the outcomes. What we're currently looking after on average is a median of 8 patients, with a fairly narrow interquartile range. And if it's broken down, I broke it down from metropolitan, private, regional, rural, and tertiary. There's a little bit of variation around that, but there's more than anything, it's fairly consistent. One of the limitations in some way with the data that is published so far and what we know is all the additional confounding things like the number of days worked, whether there's changes on the weekend. So we've tried to capture that too. And again, this is just a very preliminary look at the data, but the median number of days worked for our senior specialists at the moment in a row, consecutive days, is 5. With some variation again between the different types of units that we work in, and a bit more. The high end of the range was 8. No unit was willing to admit that they did more than 8 days in a row. And that's data from a substantial number of units. I couldn't find nearly the same amount or quality of data looking at an equally important area, which is the nursing ratios to various interventions we do. There's a Cochrane review that suggests there's really very little high-quality data looking at what is the relationship between nursing ratios and outcomes of patients. We asked for some targeted sort of areas what the standard ratios were in the units. I was kind of surprised to see the breakdown in NIV. It's nearly 50-50. You know, you might think that these patients are sometimes harder to look after and more resource intensive than a ventilated patient, and yet 40% of units nurse them 1 to 2. One even nurses them 1 to 3. Renal replacement therapy almost exclusively nursed 1-to-1 in Australia and New Zealand. I didn't put mechanical ventilation up there because it's 100% nurse 1-to-1. We did ask that. And again, there's variation in ECMO, and monitoring was interesting too. A little bit stretching out to 1 to 3, which is not something we do in any of the units I work in, but it seems to be reasonably practiced around the place. Again, I picked out some numbers. We've looked at all the different allied health at all the time, weekend, and weekday, day and night. But I just picked out a few. Alex Sirides gave a fabulous talk yesterday on handover and the ward round, and pulled out some Canadian data where I think the respiratory therapists were almost as highly represented as the intensivists on their ward round, and yet shows the importance of having our own data from Australia and New Zealand, because they're virtually non-existent in our units. On weekdays even. Physiotherapists almost exclusively, they're almost universally present on the weekdays in our units, but weekend nights drops down to 17% of units report having physios available. And again, I thought it was interesting that at the weekend, pharmacists were there in less than half of units, and likewise dietitians and social workers drop off a lot. So there's tremendous variability around what we do that is yet to be really well described. So that's sort of a really brief snapshot of some of the workforce issues around the variability. I thought also, one of the topics that keeps coming up is the burden of MET and what we perceive as the increasing burden of MET call. And when we consider staffing, it's often our FTE, often we relate it back to the patients we look after in the unit. But I think our feeling is that over time we do more and more outside of the unit, and it's hard to account for that. But have a look at this, the MET calls per available ICU bed, and the way that has just skyrocketed. So that is doubled over time. And when you look at the resulting ICU admissions, it has not increased at nearly the same rate. And that's just the MET call ICU admissions. So it doesn't take into account the fact that that's diminished the non-MET call ward ICU admissions. So in fact, we've had this huge increase in MET calls whilst we're still looking after really the same proportional patients in the ICU. So it has placed increasing demands on what we do. And briefly, the last thing I thought I'd touch on in terms of workforce was composition, because it's, again, topical. And this has come out, I think, just last week. Bala's led a group looking at women in intensive care around the world, but really there's a heavy weighting of the data in this paper from the College of Intensive Care. And on the right, you'll see sort of some trends over time, both in trainees, proportion that are women, fellows, and also representation both at the college level and at meetings. So mostly increasing, but still lower than what you might expect. If we now ask at the consultant level for the gender breakdown, both in the number of people and the FTE represented. So if you look at the FTE, the female FTE as a median of the total FTE, about 20% of the total FTE at the moment is occupied by women, and there's some variability as well between the different types of units. If you look at the female staff per female FTE, so how many women are filling each FTE of female FTE, it's about 1.3. And again, there's variety. But clearly, only looking at that, only about 25% of women in consultant roles are working a full 1 FTE. That's actually not nearly as bad as what's available to our registrars. We asked about part-time registrar positions as well, and currently only 19 units across Australia and New Zealand report having part-time registrar positions. So it might not be optimal yet for our consultants, but it's probably even worse for our trainees. So CCR, I think, is a fabulous resource. As I said, I think it's underused. It can give this great aggregate snapshot and trends over time. If anything, where at least one of the areas I think it can really go is merging then with the APD. So just as we've had the data from the UK looking at actually patient outcomes, we have the capacity at CORE to merge our CCR data, for example, related to FTE with patient-level outcome data and provide similar sorts of analyses that we've seen from the UK. And we can extend that now beyond that, taking into account other factors like consecutive days work, differences with the weekend, different staffing patterns. So whether it's consultant FTE that's of interest to you, nursing, allied health, there's these opportunities for the mergers of the database that I think can provide some fabulous and ongoing insights, and also potentially down the line new benchmarking models I think that could also be really interesting too. So I don't think we know exactly what the Goldilocks zone is yet for our resourcing of ICU, and the fact that there's all these different models around and that we all contribute to a pooled database gives us the opportunity to sort of look for the optimal habitable zone and continue on that journey. So thank you very much.
Thank you, Ed. Any questions for Ed? Have to make one up.
Don't have to make one up.
I was going to think of something. Earlier you were talking about the staffing per bed, specialists, which doesn't take into account the occupancy.
Yeah.
But then we don't tend to vary the number of doctors we have when we get more patients. And I was going to present some stuff soon about doctors per 1,000 patient days. Which of those two do you think is the sort of better way of measuring it?
Yeah, I think you should look at both. I mean, both have different, a high turnover might give you more bed days, but they're probably lower acuity unless you're killing them all really quickly. So, I think probably both are relevant, and both have subtle differences in their interpretation, so probably should be looked at side by side.
Okay. All right, then, without further ado, we'll move on to the next speaker, which is